The smaller people are just like the adults. So we know that the tumor is rare in pediatrics, and it may be sporadic, as the adults said. And increasingly, we are seeing that what we thought was sporadic, 24% of them may actually be inherited. So it may not be as sporadic as we think. So, and those that are not sporadic are associated with the syndromes just right above there. So up to 20% of Pheo are diagnosed in children as compared to adults. So Dr. Makumbi was wondering why more older people than younger people. Only 20% of the Pheos are found in children. And also to this is that many times in our settings, rarely do we get blood pressures done. Many times people thinking infection, 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 rarely do we think of the non-communicable diseases. So Pheo in other settings, you saw on the presentation of Dr. Makumbi, in the United States, they got about 1,000 of them in 1 year. But it's because they have routine screening. They will actually catch a pheochromocytoma even when they are not yet symptomatic. So people who have hereditary syndromes or families with pheochromocytoma will undergo screening. So they will actually get more people who will have the pheochromocytoma than in our setting. So Dr. Makumbi, since 27 may double or triple if we begin to screen their family members. So most are functional tumors, as you will see. Most pheochromocytomas are functional. They secrete catecholamines, and that's why we are using metanephrines. And good enough that most of them are benign. Only 12% are malignant. So we've been talking about genetic counseling because the sporadic that we thought were actually sporadic, we are thinking they are mutations in the genes. So what are the clinical presentations? They are not different in pediatrics. So in pediatric, we will also find that the symptoms are either due to the catecholamine hypersecretion or tumor mass effect. And the signs are typically the same as they presented in the adult patient. But only because the symptoms in a child may be very difficult, they will be subtle. So many people may not pick them. So a child will get collapse, or they think maybe, and gets pale, and we think maybe it's anemia. And yet it's actually a rise in the BP. But there are also the non-specific symptoms that we see in children. Weight loss, unexplained weight loss, poor performance in school, because many times people think they're anxious. They are having other diseases because, they are scared in school. But sometimes it's because of the catecholamine release. But we also have the non-secretory tumors that can give us symptoms that are really non-specific, that won't help you get to where you want to go. And really it's because of the pressure symptoms. So, and one thing that has come up is, for example, you're screening a child, a normal screening, and you find that there's a pheochromocytoma that is asymptomatic. It's there. Do you go ahead to remove it? Do you subject them to surgery? Because there's instances like that. So that has been the debate. So the diagnosis is the same as in adults. We would prefer plasma metanephrines, but they are not readily available here, so we do not usually use that. We use VMA. But of course, many a time we will miss it, and more so in pediatrics. It's thought that sometimes we will have that cycle, so you may miss it. So, but once you use the plasma metanephrines, you are really sure you will pick. So many drugs, they've talked about them, they may actually interfere and give you false positive tests. And the fact that you have to be in supine position, because of course if you're putting in a cannula and the child cries, you will definitely release catecholamines even in a normal person like me. So radiographic studies, the radiologists are here to tell us. And of course many people think that abdominal ultrasound scan has no role, but in pediatrics, because the children are thinner, there could be a role in people where they have very good local expertise as Faith will tell us more about that. So since they're going to talk about radiography, we will leave that to them. The management is the same as in adults. We would need to prepare the child well before surgery to prevent any catastrophes. As we've seen, you use prazosin. In pediatrics, phenoxybenzamine is better. So we prefer phenoxybenzamine if you can get it. It's less side effects in pediatrics compared to adults. And of course, the other drugs that they talked about, prazosin, calcium channel blockers, can be used. And once we've achieved the blockade and the hypertension is steady, it's advisable that you use a beta blocker on addition to prevent the tachycardia that we see. And thereafter, you can actually maintain the blood pressure, to prevent hypotension after removing of the tumor. You have to load with salt. Either they take it in orally. If they are breastfeeding kids, you can actually express the milk and add salt to it. Or else you actually make drops of salt, salty drops, and you drop them on the tongue just before they breastfeed. Or else, if you can't do that, you can admit the patient and give them IV fluids. But in children, remember the overload for fluid. So thank you.